Thank you very much for opening our eyes to the changes which are going to come, which will make pediatric urology unrecognizable in the future compared with how it is today. But there are already in this world people for whom the pediatric urology we see today is not recognizable. And in terms of the future of pediatric urology, I think that this is the manner in which our second speaker is going to address the question of the future of pediatric urology. Of course, Professor deVries is well known to many of you, if not most of you, if not all of you, and she's famous throughout the world for her medical missions, bringing surgical expertise to all four corners of the world. And her destination list reads like a travel agent's no-go list. Except when you read down her CV and you note that she also has a license for controlled substances, you begin to wonder what her global activity is there for. She lives in a ranch in Wyoming, along with 499,000 other people, I think 500,000 people wise enough to live in Wyoming. And she works out of Salt Lake City, which is a few hours' drive away, where she heads up a center for global surgery within the university. The Italian author, Arianna Ceccioni, made a quixotic observation that the past must be in front of us and the future behind us. And the reason for that is that we can see the past, it's in front of us. We cannot see the future, it must be behind us. I think that what Catherine is going to do is to look forward and see how we can transfer what we can see into the future for others, which at present lies behind them. Catherine, thank you very much.
Well, it is a true honor to be here with some of the heroes of pediatric urology, people I have known from a distance for years and years, and people who have been friends and very close friends for quite a long time. It's also an honor to be able to talk about something that's dear to my heart, which is global pediatric urology and global surgery in general. I think the future of pediatric urology depends on a lot of things, but a lot of those things involve engaging with the whole rest of the world. Whether we see things from far, far away, or whether we see things from a ranch in Wyoming, we see things from different sides. You can see where the electricity is by the lights that we can see from afar. In places where there's no electricity, there's no pediatric urology. Just about everything we need depends on technology, and technology runs on electricity. We also know that 5 billion people on the planet lack access to safe, affordable, and surgical care which does not impoverish them. This is a truth that we forget a lot of the time when we live in the global north and we have health systems that allow us to access care, and especially for our children. But it's a big problem for people in low-resource countries. We know that disparities pervade healthcare globally. But can these large ends be achieved with limited means? Who's going to pay for all this stuff? Well, we do know that in the 1960s, we did get a guy up to the moon, and that could be done with some fairly limited technology. Now, when I show this slide to college students, it's not unusual for them to look at me quizzically and say, well, what is that thing? They've never seen a slide rule, and they don't know that engineers in the 60s, in fact, when I was in college, used slide rules, and that was all we had. We didn't even have pocket calculators. It is possible to do big things with limited technology. But we do have a surgeon's eye view which can be a little bit limited. And I, as a surgeon, am fully guilty of this. As Professor Kalfa just mentioned, public health is an integral part of any kind of health, and we very often neglect it in our training of surgery. Policy and law has a lot to do with what we're able to do all over the world. What do we know about that? We left it all in college, and we often don't engage, especially if we have very busy clinical loads. Economics and business has tremendous impact on who pays for health care. We see this in the United States every day. In other places with other systems, perhaps it's not as a big a daily problem, but it is a problem we need to address. Technology and innovation, I can't begin to touch Professor Kalfa in his beautiful description of it, but we live by technology and disruptive innovation. And it's this disruptive innovation, or you could say leapfrog innovation, if you like that term better, which is going to help us in low-resource countries. And then education. Education we do every day if we're in academics, and hopefully we become educated ourselves. But when I first started, I had the look through the loops, and I looked down at very small things, and my focus was learning the craft, as I think most of us do. And when we start our practices, that's what we want to learn. How do we do it? And we want to be surgeons. But it wasn't long after that I started traveling, and I started going to places where this was the common thing. There were mothers and babies sharing gurneys out in the hallway. That was 1992, but it's not too unusual even now. It happens in many countries, and it hasn't changed everywhere. There are relics of past threats, polio and cholera, and we think we're over all of that. Maybe we are with polio, but maybe not with cholera. There was an outbreak of cholera not long ago in Haiti, and cholera pops up here, there, and everywhere. We have thought for a long time that we've moved beyond infectious disease, but everyone in this room now knows that infectious disease has reared its ugly head again, and we are all now subject to it. The surgical ecosystem is not unique to any one country. It's more or less the same in every country. I've only had a chance to look at about 37 of them, but everywhere I go, we face many of the same challenges, and we have to look at what is necessary and essential and what is perhaps optional. In low-income countries, there are big challenges, and those are geographic distance. For example, in Africa, a person wanting to travel from East to West Africa very often has to come up through Europe to do so. Getting visas is not easy or cheap. It's hard to get to the United States, it's hard to get to Europe, it's hard to get around if you're from a low-resource country. It's not just the expense, it's all of the restricted policies in our various different countries. There's unstable but improving communication, and that's really been improved by WhatsApp and other applications. Things like Zoom that have come in strong recently have improved communications amazingly. But we still suffer from inconsistent and unstable electricity in many, many places. It's not at all unusual to lose electricity in the middle of a case in many places in Africa. At nighttime, you're out of luck totally if you're in the middle of an emergency operation. Fortunately, people now have cell phones, and they can do it by the light of the cell phone, but we're still limited by electricity. Just when we thought that was a low-resource country problem, we also have that in California with wildfires. And for days at a time, major parts of the state of California, including Silicon Valley, lost power. Wildfires, floods, hurricanes, all kinds of things we are now starting to see are making our own lives a little bit less stable than we thought it was. Supply chain here in England are suffering right now from petrol, but it's not just in England, it's everywhere, and patchy education. My friend Paul Farmer is a public health guy. He's well known for his work with TB and other diseases, but he has an interest in surgery, and I think that he has distilled some of these concepts into some really easy to remember ways, and I like to talk to students about it because as my memory fails, so does theirs. Staff, stuff, space, and system is a great way to remember what we need. We all need trained nurses. It's not sufficient to train surgeons. It's not sufficient to train medical students. Nursing is often neglected, and nursing is very often seen as an ancillary function of what we do, but outcomes depend on nurses who know what we're doing and have trained in parallel with us. Training nurses everywhere is critical. Anesthesia, that's even more critical than surgery. And the anesthesiologists in low-resource countries are fewer than there are in all the high-income countries and all the global north. Pain management, and especially pediatric anesthesia. In most places, the small tubes that are used for intubation are not available. Most anesthesiologists do not know how to do good regional anesthesia, including epidurals, spinals, and other regional blocks. It's just plain not known. And we can't do the kind of surgery that we take for granted unless we address those problems along with our own. Radiology. We see a lot of digital radiology. We expect it. But many places are struggling to get through from film, which they did have, to digital forms. So about the time Eastman Kodak stopped supporting film radiology, that put a lot of people in low-resource countries in a lot of pain because all of a sudden they could not get an X-ray, and they have not altogether moved to digital. That's a very expensive machine and hard to acquire and maintain. Ultrasound is good, but it's operator dependent, and it requires training ultrasound techs or surgeons or radiologists, and to be able to communicate all of that stuff digitally to the people who need it. These are not trivial problems. Fluoroscopy. I have seen beautiful fluoroscopes sitting in the warehouses that are hung up just getting through the customs in low-resource countries because people hadn't thought that they had to pay for the customs tax. Does this matter to us? It does if we want to promote good pediatric urology. Pathology is the same. Anatomic, tissue pathology, lab, microbiology, immunology, blood bank, those are basics. But I think, getting back to what Dr. Kalfa was saying, that point-of-care pathology has the ability to transform many of our diagnostics and possibly therapeutics in ways that will overcome a lot of these logistical problems. Training pathologists is critical in low-resource countries, and we just plain don't have them. Then there's the issue of staff in these countries. Why would you stay in a country that doesn't support you? Would we stay? Do we stay? Most of us have migrated somewhere from wherever we started. We sometimes think of that as brain drain when we think about other people leaving their country and going somewhere else to get education and training, but they go because they're lacking support, they're lacking infrastructure, they feel isolated. In the country of Uganda, which is a big country, there is only one current pediatric urologist. She is very busy. The other pediatric urologist recently retired. That's a big country. It's easy to be isolated. And that's true in many, many places. The isolation can be crippling, and people are tempted to travel. Patients can't pay most places. In places where there is a good insurance system, it's not an issue. But for many young families, patients can't pay, and then they don't get cared for unless it's a charity operation, and then lack of consumables and supplies. So the migration of health professionals is not a trivial problem. People will leave if they don't have all the stuff we just talked about. And why wouldn't you? In Africa, one time at Kenyatta Hospital, I spoke with the medical students who were just graduating, and I asked what they were going into, thinking that they'd tell me, well, surgery or internal medicine or something like this. But no, they were saying, okay, we're going to South Africa. You know, that's where they're going. They're not going into a specialty, or at least that's what's high on their minds. So it's not a trivial problem that the people who are getting good basic training are looking elsewhere for professional satisfaction. But, you know, we really can't criticize. This happens to be my own migration route. I started off in California, and then I went back east, and I came back to California, and then I went back east again, and I've gone coast to coast to coast to coast, and finally settled in the Intermountain West for the last 21 years or so. But we do this, and we think that it's normal, and so does everybody else if they get the chance. So who are the pediatric urologists, and what's the trend in the United States? And in the United States, they just completed the 2020 census, and the pediatric urologists actually are increasing. From 2017, there were 702. In 2020, there were 1,015. That's despite the fact that in the US, we now have 1.5 million fewer kids. So we have fewer kids, we have more pediatric urologists, and the other reconstructive surgeons who will take care of our kids when they become adults, the female pelvic medicine and the male GU reconstruction guys, the transitional medicine people, they are going to be the ones inheriting it. Well, they're not really growing at the same rate that pediatric urology is. So you got to wonder, who's going to be doing what as we keep training all these new young people? Technology may answer some of this, but I think there's a greater need, and many of those places will be in Africa, where the net reproduction rate is not below replacement rate. So you can see where the net reproduction rate has fallen below replacement, and that includes all the places in blue, and some of the places in green are already there. But Africa and a few other countries have the burden of disease, and that's where the action will be, I think, if we choose to approach the problem. And it's a choice. The average annual rate of population change in the 2025 to 2030, according to the UN, looks like Africa's going to be where the population change continues to increase. And the age groups by region confirm this. Looking at the under 15-year-olds in Africa, that's 40%. That's a lot of kids. Kind of scary if you have kids that age, but there's a lot of them. And everywhere else, including Europe and the United States, the pediatric population under 15 is now dropped below 20% and is projected to continue doing that for the years in the future. So this is not new. The physicians, and this is not surgeons, but all the physicians per 10,000, according to WHO, is dramatically fewer, and we know this in Africa. But here's another way to depict it. This is from the World Bank, and this shows that in Africa, where there is 24% of the global burden of disease, there's only 3% of health workers and less than 1% of the world's financial resources. This really gets to what the problems are and what we need to address if we want to solve these problems for those kids. They need, getting back to Paul Farmer, the right stuff, stuff, and the right stuff does not include this kind of an irrigation system, which I saw at a prominent teaching hospital in Uganda a few years ago. This is the irrigation system for cystoscopy. Other places have better looking containers, but this is not unusual. Irrigation tubing is hard to find. You can find IV tubing, irrigation tubing, not so much. Things we take for granted. Sterile water. Good luck with that. Sterile saline, yes. Sterile water, no. And it won't come in a bag either. These things have to be thought about and planned for. All the scopes we know and like, cystoscopes, resectoscopes, laparoscopes, nephroscopes, ureteroscopes, all those scopes, they're not there. When I asked a colleague of ours in Uganda what she really, really needed, she said she needs one good pediatric cystoscope. This is the person taking care of the kids for most of the country. One good pediatric cystoscope. But people are smart. They adapt. They can make a cystoscope into a laparoscope if they have to with a blood pressure cuff. But we also have misguided attempts to help people with some of the problems we know they have. And the lithotripsy room that you see on the right was a donation to a hospital in Vietnam. This kind of thing takes up space. They don't have the consumables to make it work. They never did. Sat unused for years and years. They dusted it off daily because they knew it was valuable, but they never used it because they didn't have all the consumables to make it work. And this kind of dumped technology, things that are offered in good spirit, but not useful for people in the places where they're given. The actual supply chain, the stuff that people really need, is unstable. This is from Africa. This happens to be Liberia, but it's not unusual if you travel the roads in Africa, many places. This is how stuff gets around. And the supply chain is very unstable there. But it doesn't help just to bring it with medical mission trips. I mean, that will work for a temporary workshop, but that's not a sustainable thing. What's sustainable is figuring out who sells what to whom, what does it cost, how is it sourced, and looking at the big picture for that. And then we have waste management, and if you go behind the scenes around the back of the hospitals, in many, many places, you find these waste dumps that have an incinerator, and they get rid of everything from, whatever's in the OR to old wheelchairs. And almost every hospital I've ever been to has these things. But Pogo in 1971 had this cartoon, "We've met the enemy and he is us." And that's referring to the trash. We have accumulated, even at that time, trash that really impacts our planet. And I'm not just talking about the stuff you can see on the ground. It's the stuff we saw in the last presentation. It's all of the trash. And we need to start thinking about how we as surgeons make this kind of trash, use it, the packaging, all of the supplies that we use, single use, that all has to be rethought if we're really going to consider what the planet needs in addition to what our individual patients might need. Space, operating rooms, that's where we work. And it's important to have good quality operating rooms for children. You can't just adapt an adult operating room for kids. You all know that doesn't work too well. But there are very few organizations that really address the problem. Kids OR is a Scottish charity that does, and they have been building operating theaters in many countries, and it's one of the most beneficial outreach projects that I've seen that supports pediatric surgery. Well, getting on to the systems. Systems you can think of in the big sense and in the small sense. But in the big sense, what do we all need and who needs it? We need to start advocating at places that are not familiar to us. The first time I went to Geneva, I needed a medical student to lead me around by the hand. They seemed to know their way. To go to the UN, to the World Health Assembly, and to argue in favor of surgery being a part of universal health care. We never had to do that before. It never seemed to us that it was necessary to argue. It seems self-evident. You know, a problem is there, we fix it. That's not true for most of the world. They don't see that surgeons need help. They think surgeons don't need help. We've got what we already need and want. What they don't see is how many children and adults are crippled by conditions that can be treated surgically. And making that case has been the focus of a large community now known as global surgery. We've been to the UN General Assembly just finished in September. There were side meetings on surgery. The WHO has the GSIC, which is the Global Initiative for Emergency and Essential Surgical Care. The World Bank has now put out publications, and thanks to Jim Kim, who really, along with Paul Farmer and John Mira, made the case that World Bank needs to think about surgical care. Now there are priorities and indicators. There's philanthropy and development funds, the Global Surgery Foundation, USAID, FCDO, which used to be DFID, and other development funds can be brought to bear if we know that we want them and we know how to get them. National health priorities in the countries where people need the surgical care. And we need to make the case, and people in those countries need to make the case to their own ministries of health. Well, how do they do that? There's now been a template. It's called NSOAPs, and I'll speak more about that in a minute. NSOAP stands for National Surgical Obstetric Anesthesia Plans. So we can bundle what we need for systems and staff and so forth into something that's understandable to a minister of finance or a minister of health. And SOTA, which is surgical obstetric trauma and anesthesia. Trauma is actually kind of a big focus right now. Facility standards and accreditation will help bring up the standards in places where there is no post-anesthesia recovery, for example. Many places don't have it. Shocking, but true. And insurance and payment schemes. So around 2010 to 2015, there was a big movement of the global surgery community to get the attention of the World Health Assembly and to get a resolution onto the platform. And it was led by a Zambian orthopedist named Emmanuel Makasa, but co-signed by Vietnam and other countries to strengthen emergency and essential surgical care and anesthesia as a component of universal health coverage. This was a big victory. We were there. It was celebrated all around. We now have publications. For years, we couldn't get published in journals on anything. We had to start writing books because the journals wouldn't take the articles. And so there were books. There's a book, actually this photo is of a pediatric urology in Mongolia. But there have now been quite a few books on academic global surgery, and there are now divisions of academic global surgery in many departments. And this one on the lower right, Essential Surgery, was published by the World Bank. Lancet Commission put together its publication in 2015, which has driven a lot of this work and articulated that 5 billion people lack access to safe, affordable surgical care. And then it goes on to talk about how many million operations are needed to fill the unmet need, the investment, and then a proclamation about surgery as part of universal health care. But here's the framework. And the framework involves understanding infrastructure, workforce, service delivery, financing, and information management. This is the kind of stuff that talks to politicians and the people who make the decisions for the environments in which we work. Concurrently with that is a group that coalesced to address children's surgery. And this is the Geeks, the Global Initiative for Children's Surgery. We, Urology, have a subgroup there. It is led by a surgeon in Côte d'Ivoire, but we're working together with her and trying to build a network to support children's urology around the world. And this is a really good way to do it. The accountability equals data, and getting data is very difficult in places that are still paper palaces. There's been some transformation, and I think the cell phone is probably what's going to do it. And the reason I say this is because everybody has one or three in their pockets. And that's the way that people can communicate. If we depend on hardwired systems within hospitals, I think it won't happen anywhere near fast enough. There's just not the money, and there's not the will to do it in most hospitals, other than private hospitals in low-resource countries. Phyllis Kiza is the pediatric urologist I referred to earlier, who did and published in this journal a survey of unmet pediatric urological needs in low and middle income countries. And I think this was a great start. It wasn't complete because she was surveying members of organizations of mostly high-income countries, and they often haven't been there and taken a look at the problems. But we've had technical failures, we have conceptual failures, and we have system failures. The most common thing that people say they need and want help with is hypospadias. Why? Well, that seems to be something you can do something about. That is something you can get your hands on and fix. Neural tube defects, though, are harder. Cancer, exstrophy, transitional care, DSD, those are hard problems. Hypospadias is an approachable problem, and if you're going to start somewhere, that's a good place to start because the outcomes are more easy to control. My friends and colleagues in the PAUSA, the Pan-African Urological Surgeons Association, recommended power teams as a way to start to approach this. And many of us have been doing something similar to this. We've been putting together teams in each subspecialty, including anesthesia, surgery, nursing. We work together. We rotate to the teaching centers to build a cadre of teachers in the places where there's need. And I've had the great joy to work with surgeons from all over the world in these kinds of teams, because when else do we have a chance to do it? We don't have the chance. I can't work with one of my colleagues from Chile unless I happen to be in Kenya, and we're both there. So we have much to learn as well as much to teach. But it's a really powerful educational model. These are the kinds of people who need to be involved: the anesthesia, the radiology, pathology, all of them. Academics, societies, and national systems. Here are just some of those: colleges, societies, and consortia, and they include COSEXA, which is the College of Surgeons of East Central and Southern Africa, the West African College, the Pediatric Surgeons of Africa, and I don't want to neglect Asia, because Asia has a large population and still very much needed, even though Africa seems to be a focus of much of the world's energy right now. In academics, there are now popping up divisions of global surgery everywhere. And one of the most exciting aspects of all of this is this organization called Incision. Incision is the trainees. Incision is the trainees and the students for global surgery. These kids are smart, they're motivated, they want to do something about global surgery, and they put on amazing meetings where they're pulling their faculty from all over the world. I've met so many people on Incision meetings. They get together on platforms I never even knew existed, like Clubhouse, where they're having dialogues real time around the world, in Iran, in Colombia, in Vietnam, all simultaneously. And we can use some of these kinds of technology and communication. We don't need landlines anymore, 2 of them simultaneously if you really wanted to talk back in the days. Some things don't work. Google Glass is an example. Some neat, cool tech just plain doesn't work for a variety of reasons, some of them social. It's not that the idea was bad, but it had to do with people with marketing this to the population that would take these also inside restrooms and other places they might not be useful to have them. But now taking that same idea, you can go to Honduras, for example, as in this picture. There's a pediatric urology team in Honduras showing what they're doing to people who couldn't stand around the table. We still are missing the problem of haptics. You can't really teach some of the hands-on surgery. I'm not talking about robots, but the hands-on surgery, you need to be there. And I don't quite know how virtual surgery is going to deal with a haptic problem yet. So I mentioned before that the system is more fragile than we thought in high-income countries. And I think part of the problem is that we have an early and irreversible differentiation to urological subspecialties. We would do well to stay a little longer, to linger with some of the general surgeons, to learn what the ENT guys know, to learn what some of these other fields know, and not to get off too far into our smaller branches. We are dependent on technology to the point where we sometimes don't know how to do an open case. I know residents who can finish their training and not ever having done an open nephrectomy. Overdependence on technology may be our Achilles heel. We have too many specialists, I think, for our own populations. But that doesn't mean there's too many specialists altogether. We've got more than enough we can share if we make it possible and easy. And then the hospitals, we discovered, are at risk now. In the States, ransomware has become a big deal. Climate change threatens our own systems, so we are more fragile. We have some of this growing divide that we can recognize, and if we do recognize it, we can start crossing the bridge. And we can bring simple things like scopes and make them more accessible, and then move on to some of the other more technical stuff. So I have a to-do list. And my to-do list would be to resist isolation in our own operating theaters, that we play together, and by that I mean we operate together. We work together in many countries, and we don't allow the regulators to keep us in our own silos. We reconsider the wisdom of early specialization, and we plan for career resilience. Thank you.